Okay, let's move on. Right now I'd like to introduce Dr. David Williams, and he is going to be talking about dental health and vascular healing.
I thought I'd never get my chance. What a time to stand up in the middle of the heat, you know. So the School of Fish thing, I love that. So I guess that makes me probably a crustacean in this setting. So I'll do my best to try to fit in. I'm a dentist from Okotoks, Alberta, Canada, for those of you who don't know me. I have had a passion for all things neurological since early in my practice, very focused on MS. Some interesting experiences early on that led me to be very curious about the anatomy of course, my focused area as a dentist, TM joints and the skull bones. I did a lot, like decades of looking at cadavers of MS patients and found some interesting phenomena which led to a study, but I don't want to tell you the study just yet. So this is the slide changer here. Which do I push? Do you know? Whoops, not that. Which way? Forward.
You got it?
Nope. There we go. This is a slide I took with my iPhone in the meetings in Scotland, and I really feel like we should, in order for me to present my material, we need to kind of step back from the conversations about CCSVI and the vein it's been done. Oh, that was a pun. I didn't mean to do that. But the lesions, it says, are not likely to be a direct trigger of MS. And it says there may be another factor that initiates pathologic processes in the central nervous system. It could be conjectured that a combination of CCSVI and that not yet recognized factor leads to the clinically overt MS and the other neurological symptoms. I'd like to talk about other factors. And being far outside the school of fish, I'm sort of in an enviable position. I can say anything I want. And so I would like to start by suggesting that since Dr. Zamboni made this incredible revelation for us, it wasn't, of course, new. It's been said before, but he brought it to light. I'd like to point out to you that all the other things that we know for sure about neurological illness, especially MS, are still true. The fact that we've been focusing on vascular issues does not change the fact that women get MS more than men, yada, yada. I don't want to explain all of them because you know what I'm talking about. Those are still true. And one of the things of stepping back is to look at CCSVI and keep looking at it in light of what we already know. And I feel like being outside the field of neurology or whatever, vascular surgery, I have that privilege. I can back all the way up to the creation or the Big Bang if I want, because I don't have a vested interest in it as a profession. But as a dentist, I care about what's happening to the patients. And based on some of the things that I found early on in my practice, I was able to implement some changes in their bites. And I have MS patients today who have been symptom-free for over 10 years, 12, 15 years. And all I did was change some things in their bite. And that, if that doesn't hook you, I don't know what does. I have never been able to turn away from this because the difference it made for those patients. So it's led me to discover some interesting things. I just want to mention a few important points before I tell you about my study. So there's lots of papers on sleep disturbance in MS patients. The association of MS and trigeminal neuralgia. When I presented in Victoria, I was not inundated, but I had a lot of people coming up and ask me, what about my clenching my teeth? What about my teeth? What about fillings? What about old root canals? What about trigeminal neuralgias? And there was a lot of, it seemed to resonate with the crowd quite a bit as far as their experience of their illness and how it progresses. The incidence of headaches in MS is twice as high as the rest of the population. Dominance of jugular flow. Now, when you're standing up, of course, I'm not the specialist in the flow of blood, but I know that there are big differences between the way the blood flows out of your skull when you're standing versus laying down, which ties back into sleep studies. During your sleep, I'm speaking as a dentist now, if we put a bite meter between your teeth right now, and I say bite as hard as you can, we'll get a number. And if we keep that in during your sleep cycle, there are periods during your sleep, interestingly during REM sleep, when there's not supposed to be any muscle activity. In the rest of your body it's completely shut down, but you can clench, and the factors, I don't even want to say how high they say they go, at least double. Okay, so we're talking hundreds and hundreds of pounds of force registered. The highest recorded is like 1,200 pounds. Do you know how much weight that is at the back molars? Well, that has to come from somewhere, and the muscles that are involved, basically it's a vice around your whole head. And so can that have an impact? It isn't just one group of muscles. It engages the muscles, the SCMs down here, the entire shoulder girdle and the skull bones are put under extremely high stresses during short bursts of sleep, okay? And so with that background, what I'm trying to suggest here is that we've got a history of vitamin D. What's the role of vitamin D? Why is vitamin D? You know, those are very, very good studies, and they show that vitamin D plays a big role. What's the role of vitamin D? Formation of what? Bones and ligaments, okay? The role of dental pathogens and venous inflammation and collagen deterioration. This has just become a real big part of this recently for me, discovering that there are germs, specifically spirochetes, which look like little corkscrews under a microscope. And they are related to, this is going to get gross, syphilis and Lyme disease. And the dental spirochetes are called Treponema denticola, and that bug is specifically related to periodontal disease. They are very closely associated with metal toxicities. So the increase in metal toxicities activates these bacteria, and their pathogenicity is increased. The role of relaxin, as far as the incidence of MS among men and women, of course women, this happened yesterday actually in my practice, and I was mentioning something about this, and two of my assistants and my receptionist said, what do you mean? And I showed them how far I can reach behind my back like this. And they can reach up and see their fingers over their left shoulder when they reach behind their back. And I said, that's what I'm talking about. Women have relaxin as a part of their system, and it's always there, and of course it ramps up during pregnancy. And what that does is it loosens up the ligaments, and I think it has an effect on the role of these pathogens directly on a particular part of the anatomy that I'm going to talk about. Okay, so a key question that I have, so we're stepping out of CCSVI and venous pathology and saying, what's causing this? Well, one of the things is inflammation. So what's the level of systemic inflammation? Specifically, the spirochetes that have been found associated with gum disease are showing to have a direct correlation, and this is very well published peer-reviewed studies, with atherosclerosis and heart disease. That's on the arterial side. I don't know of any studies that have been done on the venous side. Let's talk anatomy for a second. The pathogens that come from your mouth and these bacteria are getting into the bloodstream. Where do they go? They go directly into the facial vein, which drains in and empties into the jugular vein, and guess where? Directly where the spinous process pokes down that Dr. Arata has given me lots of feedback with his patients where he's finding these compressions, right? C2, I'll show these in the slide in a second, but these are areas of concern. Allergies to metals. Vera's poster in the thing, please take the time to read the whole poster. She's come a long ways and she's very passionate about this, and I have to echo. We can look at the health of the veins. We have to look at what's going through the veins and the pressure that's going through the veins. If you look at kidney dialysis, somebody's got a dialysis clinic that we're talking about here. When you have kidneys fail and you have to clean up the blood, they have to change the flow rate, right? They have to take the blood out and clean it up and put it back in. And what happens? I don't know what the percentages are, but I know that a significant number of patients develop central venous stenosis. From what? the venous studies show that if you increase the friction and the pressure inside the lumen of a vein, it causes change from type 1 to type 3 collagen, fibrosis, and increase in smooth muscle. Is that what we find in CCSVI? Yes, it is. So we're talking a mechanical change in pressure that could be contributing to CCSVI. Now, chronic trauma and stress to the vascular system is what I am here to announce and bring up to your attention. My studies with the anatomy led me to a discovery that the cranial sutures, which are a suture is the joint between the bones of your skull. These are membranous bone. They start as collagen as a baby, the fontanelles and all this. And as these sutures fuse, I'm suggesting that in the absence of vitamin D, in the presence of a very cold climate where you clench your teeth a lot, like up in Canada, a condition occurs where the sutures don't form properly or completely. And this does not give you MS or CCSVI, but it does leave you open to potential problems that I've just like to show. Here's my study. We found an ultrasound device that measured the intracranial dimensions in microns. It's a very, very accurate system. It was designed for the space program in San Diego. And we set up event markers and had the patients clench for 5 seconds and release, and it was a very short study. And here are the results of the study. We had 10 MS patients and 10 controls. They clenched only to 100 pounds. That's just a bit more than swallowing. That's not a lot. Anybody here can probably do 250 or 300. Okay, so the dimensional changes between the inner surface of the temporal bone changed by sixfold, 6 times more than normal. And the statistical significance at 0.008 makes it a fairly significant study. So the point, here's a graph of that, with showing the amount of movement there. So this is a schematic showing the pull of these muscles. The temporalis muscle, if you put your hand on the side of your head, the fibers run over your eyebrow, just right beside the hairs on your eyebrow, and the other one's right over the top of your ear right here. So make a hand like that. It's a 45-degree angle, and they can become very, very hypertrophic. The masseter is, of course, attached where the red arrow is there from your cheek muscles right here between the zygomatic arch and the angle of the mandible. And the SCMs run across from the massetered process down to your clavicle. And so that force is what I believe causes this. You notice where the spinous process is and where the jugular vein comes out. Now, where you see the letters SCM, that's the attachment of the SCM, but that's the temporal bone itself. And so what I've measured is a tipping of the temporal bone that causes several things. Of course, it causes a lot of things. But it causes change in pressure inside the head, very short burst change of pressure depending on how long the clench is. It causes a tilting of that spinous process. The spinous process is attached to that skull bone. So when the clenching happens, if that bone tips, it tips the spinous process into what? Right into the jugular vein. And where is C2? We've already heard this. I don't have the 3D analysis and all the fancy tools, but I know where C2 is, and it's right between where all the action is there. So we're talking about compressions and restrictions and constrictions in the upper part of the skull, or upper part of the neck, at the base of the skull. This is where I think a lot of the action happens. These are some of the slides from the cadaver work that I did. There was a step. You can see the difference. I looked at hundreds of normals, and the transition from the parietal bone on the top of your head to the temporal bone is like looking at a billiard ball. I would pan across with the video, and that's what healthy looks like. With the cadavers of the MS, there was a step there. The temporal bone is literally sticking out. When I pressed on that bone, blood came out. These are sutures in 50, 60-year-olds. And according to the medical dogma, the sutures of the skull, they're done. They're fused. They don't move. So anybody who's been through craniosacral therapy or talked to an osteopath, that's not true. The sutures do move. But this is outside the parameters of what osteopaths and craniosacral therapists are aware of. Because the dimensions we're talking about, This is the inside of the skull at the bottom of the parietal bone, and I had to take an impression of it, that's why it's green. But there was a spur at the base of the parietal bone poking out into the brain on one of these early cadavers that I looked at. So I'm pretty much done, but this is the periventricular perivenular phenomena, which we know to be the characteristic signs of MS. According to the earliest research that when I first started into this by C.F. Adams in his Atlas of MS, he said the very first thing we know about in MS is a violation of the small venules around the ventricles. And from there, the disease progresses. This is before, we heard this morning, CCSVI is late. CCSVI develops late in MS. So think of all the things that would precipitate from this. The accumulations of iron, you can see it there. That's the iron that's escaped from a small venule. These are 1 cell thick, these small venules. And so the pressure wave that I'm talking about, that I'm suggesting happens when you clench your teeth at night, causes small but definite damage, which would affect the support cells and would affect axons, which are damaged early in the disease. And so the cranial displacement causes a short burst of pressure within the cranium. The trauma to all the tissues could lead to microbleeds, which is a very important phenomenon. Amyloid expression. Amyloid is a stress protein that's produced in the presence of stress. If you fall down and hit your head on the floor and are in the hospital, one of the first things that happens is the buildup of amyloid. Axonal death, demyelination, degradation of the blood-brain barrier, etc. Another thing that we found is that vascular endothelial growth factor, I'm getting thirsty, growth factor, is produced in situations of trauma. And that is expressed downstream. And so you're going to have effects of this phenomenon affecting the blood vessels outside the skull. That's, as we continue to look for the other factors in CCSVI, the role of dental pathogens and cranial physiology related to dental dysfunction should be carefully considered in conjunction with venous stenosis. Thank you so much. That was just a pause. Hold your applause. No, just kidding. One last thing. I'm not talking about all theory here. I can tell you that there are what we call biological dentists. It's not a true designation, but they're taking out mercury fillings. They're eliminating metals of all kinds from the mouth, which agrees with Vera's studies. There are huge things to do with the way the function is. There are oral, like we're talking sleep studies, swallowing studies, sleep apnea. These things all play into this. The size of your arches. And they all play into this, and I have some great respect for ISNVD that I'm standing here making a contribution, and I hope that I have made a contribution. I hope I've stimulated your curiosity. I don't think we need double-blind clinical trials yet. What we need is curiosity. Thank you.
Thank you, Dr. Williams. Okay. Dr. Chuck Woodfield is up next, and he's going to be talking about atlas instability and CCSVI.
Okay. I want to thank Sharon for inviting me. This is real exciting. I began my studies as a pharmacist, ingrained in the medical model, and it didn't answer a bunch of my questions. I looked at chiropractic as, well, let's see what they have to offer. I worked with a doctor in Chicago, and he had miracle cases, people with MS, Parkinson's disease, that came in wheelchairs and walked out. And I said, you paid somebody to do that, right? He goes, no, talk to the MD. So that began a long process of looking at the atlas and MS. So let's do a quick anatomy. The atlas is the top bone, okay? And through it goes the spinal cord, and it helps keep your head on straight. So what happens when an atlas misaligns or it's unstable? It's a 3D misalignment. So it's, and I'll go through some theory, it kind of compresses the brainstem and the spinal cord. But what we seem to find is that it impedes the outflow of cerebral spinal fluid and venous outflow. Right? And what we think is that there's dentate ligaments at the foramen magnum, so that when the atlas misaligns, that's where you get the blockage or the impeding of the venous outflow directly on the pia. And there was some studies, I guess there was a study that showed that the compression, venous compression in the spine results in cord ischemia or anoxia, which means there's no oxygen there in the brain, in the brainstem. Okay? And this is a kind of a line drawing that'll explain everything in terms of, you know, the head tilts and the cord gets compressed. And we've actually taken a look, and you can notice the black part in the center is the spinal cord. And this is an actual shift, so that when you have a 3-degree misalignment of the atlas, you'll actually have a 23% compression of the cord and the veins and the cerebral spinal fluid. The doctor that I was talking about practices the NUCA, National Upper Cervical Chiropractic Association procedure to adjust the atlas. In each one of those doctors, they have to demonstrate their competency, which to me was, really? You know, well, this is a specialty thing. And they have a protocol that has some, it's been scrutinized scientifically, and I'm still scrutinizing it. Okay. So if you suspect somebody has an atlas misalignment, you do a simple leg check test. Okay. If one leg is short, well, we need to do a posture exam. Okay, and so that when the atlas misaligns, you get a whole cascade of different muscle contractions and so forth. It's more of a functional aspect of the misalignment. And this kind of explains how you get the short leg. And the people at NUCA have developed an instrument called the anatometer, in which you can actually measure the difference, you know, in the way the pelvis goes, if one ilium's high or the other ilium's low. You know, and if you're off center, off from the vertical axis or the gravity line. So when all these things usually go back to 0 after the atlas is corrected. They take a series of 3 different x-rays. Everybody's going, oh, I don't know, you know, you're nuking us. Well, I don't think so, because we did some studies on how much radiation exposure people get. So we take 3 different views, and we analyze the films to determine exactly how the atlas has been misaligned and what we need to do to correct it to what that person's normal is. Okay? And after the correction is made, they take another set of 2 films to verify that they actually did something. Okay? And it's about 600 millirems for a series of 5 x-rays. I think it's less than a dental bite wing. Okay, here's an example of what they call the nasium film, which determines the laterality. And I don't know if you can see, but the skull is actually tipped back to the vertical axis. And this is, it's a by hand correction. And the amazing part of it is that you don't feel it, because they position you just so, and from the x-rays, that it's just a slight touch to the side of your neck, and the atlas realigns. So I couldn't believe it. myself, except I couldn't get off the table the first time I had it done. So after I experienced working with this NUCA doctor in Chicago, and I met the MD that had been referring all of his problem cases to him, we decided, well, what are we going to do? We need to, well, let's do some case studies, and we did case studies. And we decided that we would do a double-blind randomized trial of people that had hypertension. Okay. And so we actually did it. We went to see Dr. Backrus at the University of Chicago and said, you know, here's our initial data. Will you help us? You know, he just laughed at us. He said, sure. And lo and behold, a year and a half later, the statistician looked at the data and he said, wow, you know, you actually lowered blood pressure here, and it was about 13/9 points for the 8 weeks that we studied the people. In an informal study, most of the people had the low blood pressure for a year. So I can't wait to do more study on that. So we went to the NIH because we thought that, oh, we've got something here. And they said, well, maybe not. And they said, what you need to do is take a look at that leg check test and see if you can develop it into a screening test. Okay, I can do that. But this idea you have about blood flow, you really need to decide what you're going to do with that and do something. Show us. Show me. We're not going to give you money unless you show us something. So we didn't know what to do, and I went to the University of Chicago at Illinois and I met Noam Alpern. And I explained, you know, I said, I need your help. You've got this procedure that you can image blood flow and CSF flow. Can we do a quick trial? And he was excited to do that. So we found a 62-year-old male that had migraine headaches, and he said that I'll spend the 5 hours in the tube that it's going to take to get all the initial study. And so we did it before we did the correction, and then we did it twice after, immediately after we did the correction, and then 30 days later. So 40 years of migraine headaches were gone. Okay. There was an increase of intracranial compliance, and there was a change in the venous pulsatility in the outflow pattern. So we actually had a decrease in internal jugular flow. The one on the left is the pre, and on the right is the post. And I see that the figures didn't come out on the compliance. I think it went from 9 to 17 at the end of 30 days. So, and here is another example of the changes in the venous drainage after the correction. So before we gave the correction, it was more, and the patient was in a supine position in the tube. Before we gave the correction, it was more internal jugular, and after we gave the correction, it was more extra. So we're really excited, and it took me 3 years to raise the money so that we could do a case series at 10 subjects, and we're currently doing that in Calgary, Alberta. Okay, one of Noam's collaborators, it doesn't sound right, but they looked at venous outflow in MS and in migraine patients and noted some similarities. Okay. This is Dr. Alpern's procedure. Okay. Now, we were looking at intracranial compliance because we thought, well, maybe it's not entirely the venous outflow. It has something's going on with the CSF flow. And, you know, we postulate that it has something to do with the atlas in terms of intracranial compliance. So what we do, what Dr. Alpern does is he uses MR, and he has a specific algorithm in which he calculates flow. And please work. Guess not. And the same procedure is used to calculate CSF flow. And these little movies should show up and down movement. Obviously, it's not working. So one of my colleagues took the same idea and worked with Dr. Demadian at Phonar and looked at CSF flow. And you can see the valleys and peaks before the atlas correction, and after the atlas correction, the CSF flow evened out. So we think that has something to do with CSF flow. We really want to know how that plays into CCSVI. I'm going to put in a plug for my friend Mike Flanagan. He's written an excellent book on why it might be cerebral spinal fluid, and it's real easy to read. Okay, thank you very much.
Thank you, Dr. Woodfield. So those last two presentations is just bringing in, opening up maybe a little bit different idea as far as with CCSVI. Dr. Dan Simon, would you like to come on up? And Kirsty, are you around? Where's Kirsty? She's up next. So, okay. And Dan Simon is going to be talking about thrombosis, which is something that we all need to be. If you're going to have the procedure, you need to be concerned about this. So, yeah, I'm going to set it for 9 minutes.
Great.
Okay, and then
So I have 9 minutes, and please hold me to that time. I just want to make sure I understand this. Okay. Forward, perfect. I got it. Okay. Well, you've seen controversy here today, and you've certainly seen disagreement amongst physicians. This is a topic, this idea of thrombosis. There is disagreement here. I don't think it will be a discussion that is as vituperative as the one that we saw earlier, but there's no question we're not at a point where there's agreement. I want to thank you, Sharon, for the invitation. So we've all seen images like this earlier today. Well, we did see images like that earlier today. That was a jugular vein pre-procedure. Let's see if we can get back up there. Oh, anyway. Well, we've lost power. Oh, we're back. Okay. So, you know, we've seen this earlier from some of the previous presentations. This is what we have seen in CCSVI or in patients that present. This is a venogram. That's a right jugular vein. That's us ballooning a right jugular vein, and that's a nice result, and we were happy with that. And when we see this, and this is the outcome, we're pleased. What we've come to discover is that patients don't always have this when they leave your center or weeks or months later. And in fact, I think one subject which has not really been discussed, but hopefully will be addressed, if not here, then perhaps at other meetings, we're seeing patients that the patency is not a durable result. We're seeing occlusions. We see it in this was an angioplasty. We see it following angioplasty. We see it following stent placement. It can happen early. It can happen late. What I'm going to try to focus on in this talk is this concept of thrombosis. And it's not going to address comprehensively all the reasons why vessels occlude. So I'm going to stick with thrombosis as the idea of clot. This is actually a paper I pulled. This is from our colleagues in Canada that went over complications in patients following the procedure who had returned to Canada. And they covered a number of subjects. This is actually available. You can get the full download of this paper online. It's available whether you subscribe to the Canadian Journal of Neuroscience or not. And they cover 4 patients. I think we're going to see these complications. We're tending to see them in the jugular. I suspect we'll see them in the azygos vein as well. I also want to say that what I won't discuss in my talk, it's almost as an assumption going forward, is let's not address the validity or the efficacy of the CCSVI procedure at this moment in my talk. Let's say I'm going to address really where we are in terms of these complications, or some of them, and how to prevent it. So let's now give you background, and probably the best thing I can do for you in 9 minutes or less is to let you know what's going on in the head of your doctor in terms of what they're thinking with regard to this issue of thrombosis. So we're all clear, thrombus is clot. Thrombosis is the process of clotting, so we don't get our terminology mixed up. What we know about this subject comes from 3 areas: our knowledge on arteries, veins, and the heart chamber. So let me give you background and bring you up to speed. So when we look at arteries, and perhaps you've seen this at some point in the past, this is not information that's new, or it's not been kept from the public. So our knowledge or our understanding of arterial thrombosis is the following. We tend to see plaque build up in a vessel. At some point, that plaque ruptures and serves as a nidus for blood clot formation. This tends to be an arterial process. We see it in stroke. We see it in heart attacks. It's a little different than what we see in veins. Oh, by the way, before I get to that, another area where we have focused on clot in arteries is this concept of clot, preventing clot, following an intervention, specifically an angioplasty or stent. This is just a schematic of a stent going in the carotid artery. Our experience has told us that we want to modulate or affect thrombus formation in this circumstance. There's a biology that's taking place at the interface. This is a stent inside an artery pressing a plaque, and our experience has told us we see clot, we see thrombus forming here, and we want to get it, we want to jump in and affect that process. Another area we've seen clot, we tend to intervene. We certainly have an interest here, is the idea of clot forming in veins. This is a different process, a different biology. Our vast experience in this area is veins in the legs, following hip or knee surgery. There tends to be stasis, and we develop blood clot here. And there's been a massive attempt to modulate or affect this process. This is the heart. We tend to see clot forming here. This is, in particular, this is a chamber of the heart called the left atrium. Patients can suffer from a condition called atrial fibrillation. There's abnormal contraction of this chamber. Blood tends to pool, and blood, when it pools, will tend to form clot. These patients are at risk of stroke. There's been an intense focus on treating or affecting stroke in these patients. This is something that physicians tend to know about. I will say we don't necessarily have it down as we did as medical students. This is the clotting cascade. This diagram represents years of research and history to try to understand the processes that affect blood clot formation or thrombosis. Everything we know in terms of modifying clot formation has to do with affecting these pathways. And you can see it's fairly complex. There's a number of feedback loops, modifiers, instigators, regulators. And our goal in terms of preventing clot formation is to affect various points at this pathway. In terms of blood clot and what we know, there's no question the biology and the interface of what's happening in arteries and veins is quite different. We see in an artery, there's, as I mentioned earlier, there's a fibrous cap, there's inflammation, there's cholesterol, there's macrophages, there's various mediators at that level or at the vessel wall, and that's forming clot. And then there are veins, and clot is forming, but it's definitely, or I should say, it's a vastly different biology that's taking place. Okay. Everything we know about clot, all the research, all the work up to now, has largely been studying clot in the categories of disease in patients that I've mentioned. Atrial fibrillation, coronary artery disease in arteries, stroke vis-a-vis arteries, and in veins, largely with regard to leg veins and preventing a condition called DVT or pulmonary embolism. There really isn't a vast body of literature studying thrombus in jugular veins or in the azygous vein following an angioplasty or stent placement. There are not randomized clinical trials, which, if you were listening or picked up anything from the earlier discussion, which we see sort of as the universal gold standard within medicine. There aren't randomized clinical trials looking at, how do we affect, how do we modulate clot formation, thrombus, in the jugular vein? And how do we do that following an angioplasty or stent placement? And I'll tell you this, in Hollywood, they don't like to give you the end of the movie till the end. The end of my talk I can give you now, but we'll still continue, is there's no universal agreement on how we're going to prevent, at least up to now, on how we're going to prevent clot formation or thrombus following angioplasty or stent placement in a jugular vein or azygos vein. And the significance of that is the following. When your physician is going to make a decision as to how to prevent that in you as a patient, it's really not going to be based on a study that focuses on that issue in the jugular vein. What that doctor is going to be doing is they're going to be borrowing from experience and study and research that has taken place in arteries with regard to angioplasty and stent placement, or in veins with regard to preventing blood clot formation following orthopedic surgery or trauma or in other populations of patients. Those conditions are vastly well studied. We have decades, if not almost 100 years of experience preventing clot in those patients. And we are constantly refining and improving and deriving greater efficacy from our drugs to treat those conditions. All of the research has been on evaluating those conditions. What we are doing as physicians when we are treating a patient who we believe has CCSVI is we are borrowing, we are extrapolating from that information to try to understand how to modulate the conditions that or I should say clot and in angioplasty or stent placement. So very quickly, because I'm running out of time. The way your physician is going to do this, they're going to look at the drugs that are out there. And the choices are going to be the following. They're going to have new versus old, pills versus injection. They're going to consider efficacy, clearly. They're going to look at complications. They're also going to try to understand what surveillance and monitoring issues are involved in selecting these drugs, because it's not the same for each one. Cost will be an issue. Before I came, I called CVS because we had a patient. We've had several patients without insurance who've come to see us. And I'll say, listen, I want to put you on a drug so that you're not going to potentially thrombose. We've had patients from Canada. And so when I call and I say, I want to put you on Plavix, and they're like, okay, I'll get you. And I said, why don't we get you a prescription? If you have to pay out of pocket for these drugs, it matters. So the drugs I'll talk about, Plavix, out of pocket, 1 month supply is roughly $300. Pradaxa, 1 month supply out of pocket, $300. Lovenox, 1 month supply, $800. Lovenox, we'll talk about that. So the cost does matter on these drugs, especially if providers won't cover it. With regard to providers covering drugs, some of these are now going to require insurance pre-authorization. Pradaxa, Xarelto, they will not fill the prescription unless the patient meets the diagnostic criteria for use of the drug. And I'll tell you right now, alluding to my comments earlier, no one has studied these drugs, any of these drugs, in a randomized controlled trial in patients having angioplasty or stent placement in the setting of CCSVI. The numbers just aren't there. So if the insurance providers don't want to pay for the drugs, your physician, especially with the newer drugs, will not be able to really change that decision. That being said, let's quickly run through this because I'm running out of time. The drugs of choice, your doctor will have the option of heparin or warfarin. Heparin is injectable. They'll probably use it during the procedure, but I'd be very surprised if you're on long-dose subcutaneous heparin after the procedure, but it is cheap and readily available. Warfarin, alluded to earlier, probably of the 90,000 plus mistakes, errors, and deaths that take place in medicine, on a drug side, the vast majority are this drug, warfarin. It's very good at modulating the clotting cascade. It has a tremendous amount of side effects. And I'm sure we'd love to do away with it, but it is very cheap. Low molecular weight heparin and Arixtra, these are injectable drugs, but they are very effective. The beauty of these, they don't require monitoring. Your doctor can put you on that, and they don't have to check any coagulation parameters post. These are the new boys on the block, Pradaxa and Xarelto. I actually happen to like these drugs. I've not prescribed them, but I'll tell you, they are effective, at least, again, in preventing conditions of pulmonary embolism and DVT. They have a very low side effect profile. They are oral, which is very nice as a drug. They may be expensive, but they're actually no more than Plavix and aspirin. Let's get to Plavix and aspirin, the last ones. Many physicians will place patients on Plavix and aspirin post-procedure. Aspirin, there's data that it's effective in preventing DVT. It's not as effective as low molecular weight heparin. It's not as effective as Pradaxa, but it does have some effect. What your physician is doing in terms of, what's their thinking, what's going on, they're probably borrowing from both sort of conceptual models that I showed earlier on prevention of clot. That is, they're trying to affect the platelet cascade, because these are the platelet activation, because those drugs, aspirin and Plavix, will affect that. But aspirin also gives you some effect on the coagulation cascade. Overall, on this whole issue of thrombosis, this is a sort of a maxim I live by all the time at work, which is the best way to climb out of a hole is not to get in it in the first place. And it would not be unusual or unreasonable for your physician to place you on some form of a clot-modifying drug in anticipation of your procedure. We tend to do 5 days aspirin and Plavix ahead of the procedure, and then to go 1 month to 35 days after the procedure on these agents. Again, if I haven't said it enough, I'll say it again. We don't have data that comes from randomized trials looking at this particular problem in MS patients. When your physician makes a decision on choosing their drugs, what they're doing is they're looking at a vast volume of data that exists in other conditions where they've developed a comfort level and an understanding of how these drugs work, and they're then borrowing that to say, well, I believe it should have an effect in patients after I instrument their jugular vein. Lastly, the goals are obviously prevention, treat before, medicate after. The question for how long you're going to medicate after the procedure is also a vast unknown, by the way. If a physician decides to medicate for 30 days, I would say I would tend to go 35, extrapolating from DVT data. Again, there's not an absolute right answer to any of this. It's really about judgment. When there is thrombosis, that can be treated. I don't want to get deeply into this to say you can take this, a clotted jugular vein, and convert it to this, a patent jugular vein. Once we start getting into this area, though, we're on a different part of the curve with regard to risks and benefits. The drugs to do this are a little bit different than the drugs we use to just prevent clot. There's nothing wrong with doing this. Again, it's all about judgment and sort of trying to understand the thinking of your physician with regard to risk and reward. Lastly, that's my cell phone number. That's my email. I've always given this out to patients. I've encouraged them to contact me, call me, text me. I'm pretty good at that. Feel free to do the same if you have any questions. Thank you.
Okay, thank you, Dr. Simon. Dr. Christy Duncan, I'd like to bring her on up to the podium here. And I think you all for sure from Canada recognize the name. Kirsty has been quite an advocate for the MS patient community in Canada.
10 minutes, is that right?
I'm going to set you for 9.
9? Okay, I'm going to have to move.
Yeah, move.
Let's see, look out, press. Oh, okay. Here we go. Good afternoon, everyone, and it's a real honor and privilege to be here. And I want to begin by saying thank you to the doctors who have the courage to be pioneers, to think outside the box, and to look after people who are suffering. And then I want to say thank you to all those who live with MS and who have the courage to fight their disease and then to take on the system. I'm a former health professor and now a member of Parliament, and if I could have the next slide, please. Oh, I can do it? Thank you. Now a member of Parliament, and when we first heard about CCSVI in November 2009, I thought this is interesting, and I started to read and find out as much as I could. And then, like Dr. Hubbard, I went to that first CCSVI conference in Hamilton. And I have to admit, I went skeptical. I wanted data. I wanted real research. And when I got there, they delivered. And I thought, there's something here. So with my colleague, Dr. Bennett, and I, we wrote an open letter to our health minister in Canada, and we asked that there be clinical trials and a registry. That is, do the science. Let's see if this works. Unfortunately, we got no response. Then in May of 2010, I asked for an emergency debate in Parliament about clinical trials for CCSVI. It was denied. Then I started a neurological subcommittee that had never existed on Parliament Hill. And we had Dr. Zamboni, Dr. Simca, Dr. Hakey, Dr. McDonald present and ask parliamentarians for clinical trials and a registry. This time the experts were ignored. I then asked for a 4-hour take-note debate in Parliament, and that we got. So we had the need for clinical trials debated at the highest level, but we still were no farther ahead. I'm in touch with 1,500 Canadians with MS. They have my personal email, they have my phone number, and they know when they need me, they can call. They're amazing. We've done a petition in Canada, and what that petition allows me to do, we get 25 signatures, I can speak about CCSVI in Parliament. We are pretty well talking about CCSVI every day in Parliament, and I'm sending it to all other MPs so that they can speak about CCSVI. I've asked hundreds of written questions of the government, and we've done breakfasts. We've brought the top doctors to Parliament, and so many of them are in the room here. Dr. Hubbard, Dr. Hewitt, Dr. McDonald, Dr. Hakey, Dr. McGuckin, and you should know they come at their own cost. And as they said, this is our business. And for example, most recently Dr. Hewitt was there, and he said, this was just last week, 90% of our patients are Canadian. And he came to Canada to say, please do clinical trials. In June and September, we got 2 bills into Parliament calling for a national strategy for CCSVI, asking to do clinical trials that would put Canada at the forefront of medical research, to ensure that there be follow-up care for those who have been treated, because right now there's not. There's nothing. And to make sure this expert panel we have actually have experts that have done diagnosis and treatment of CCSVI. The reality is, instead of this being a scientific process, we've had a political process. And the government worked with the MS Society in Canada. They had a meeting behind closed doors, and they decided in August of 2010 not to do clinical trials. This having been the fact that CIHR was open to trials and the president of the MS Society was willing to give money, and behind closed doors that didn't happen. They brought the federal and provincial health ministers together in September of 2010. That summer we had 8 provinces and territories pushing for action on clinical trials. In September we only had 1 province go forward. I mentioned the expert working group. None of them have done diagnosis or treatment of CCSVI. But we had some success, and that success is because of those living with MS and how hard they've pushed, and because of these doctors who have pushed for them. In March, they reversed their position and agreed to do a registry for CCSVI. And then in June, they agreed to do clinical trials. And can I share a story? I know I'm on a time limit here. I got a call from my office in Ottawa and said, "Why aren't you answering your telephone?" And I was busy with constituents. And there was something in Ryan's voice. I just went, "What's wrong?" And there was dead silence, and my non-emotional Ryan, who says, "They're going to announce clinical trials." And I said, "What did you say?" And I dropped the phone, I ran through to my office, and I was screaming in the phone to Dr. Sandy McDonald, saying, "They're going to do clinical trials, they're going to do clinical trials." And then I phoned a patient, and I said, "Turn on the CBC, they're going to announce." We'd fought a long time for that. But then, in November, they announced it was going to be a phase 1-2 trial. That will not put Canada at the forefront. The U.S. are already doing 3 FDA-approved phase 2 clinical trials. And just so you know, they announced Phase 1, Phase 2 a few days before my bill was to be debated. They also moved up a government motion that calls for information for MS patients. Calling for information does not change the status quo. So, last week, on February 9th, if any of you haven't seen it, MS Wars was aired in Canada on the CBC, on the David Suzuki, who's a very famous Canadian scientist. The next day, the Minister of Health said there would be a briefing for all MPs on Monday, 14 hours before my breakfast with Drs. Hewitt and Dr. McGuckin. And that briefing was meant to be ahead of that breakfast. On Wednesday, we had Bill C-280 calling for a national strategy debated. And folks, we have got it to a vote. Next week we're off from Parliament, but the following week the vote will come on Bill C-280. We're getting strong support from the opposition, and we're starting to get support on the other side. This motion, which calls for information, was debated the day after my bill, and it will also come up for votes on that night. So it's been a very busy week in Parliament, and I want you to know this should never have been about politics. This is a humanitarian issue. It's about people living with MS, and we shouldn't have had to fight this hard for the science. All we've asked for is the science. Yesterday, just as I was about to get on a plane, the Minister of Health sent out a letter to all MPs regarding C-280. I will respond to that letter to all MPs when I get home with new data from this conference. But I just want you to know, whatever is the result of that debate, I promise you I will keep fighting for the science, and I will keep fighting for follow-up care and to get real experts so that we get the answers we need. And I promise all those living with MS, I am always an email away. Thank you.
Thank you, Kirsty. As you can tell, she's quite an advocate for everybody, not only in Canada, but also for here in the United States. Okay, we are just about ready to do the doctor's roundtable discussion, but we're going to go back to one of the debates. And Dr. Atariwala, I think I got that right this time, Atariwala. He's going to come out, since his PowerPoint didn't work, he's going to spend like 4 minutes on his PowerPoint, and then we'll get to the doctor's roundtable. Okay.
Hopefully they'll have the time.
I'm going to,
Sure.
And I'll set you for 4 minutes, and it'll go red. Okay.
Okay.
So try to stay.
All right. Let's see. Hopefully they have them this time.
Okay.
All right.
Okay, you need to just push the button.
Yep.
There you go.
All right. I'm Dr. Terwell. I'm an engineer as well as a nuclear medicine physician and radiologist from Vancouver. This was supposed to be my debate from earlier with Eric Feinbutz, but unfortunately it didn't work. So there's some important science in this that I thought, maybe for those out there who are interested, it would be useful to learn about. So basically, first of all, I have no financial disclosures. As I mentioned earlier, the only thing I'm really interested in is science and engineering as well as MRI. So basically, what do we need for CCSVI evaluation? Well, first of all, the most important thing we need is a reproducible method for detecting it and monitoring it. We need something called inter-observer reliability, so that means it has to be used here in Orlando, it has to work in Italy, it has to work in Vancouver, it has to work everywhere, and it has to be very robust. So what is the current status of the CCSVI hypothesis? Well, we pretty much moved beyond the idea of it being blocked flow. We actually kind of think that it's likely related to increased vein outflow pressure, most importantly pressure, in either the jugular or the azygos vein or any of the venous circulation. And that increase in venous pressure is going to result in what's called Starling back pressure. Not reflux, but Starling back pressure that's going to damage the tissue around the small venules. We know that the small venules are the most susceptible in the artery-to-vein cascade to injury and pressure. So how can we measure CCSVI vein pressures? Well, it's actually impossible to measure pressures in the veins because they are so low. The only way to accurately measure them is using an invasive technique called a servo-null. It's the only way it can be done. So all the ideas of trying to measure with catheter venography, they're garbage. Garbage in equals garbage out. That's unfortunately where we are. So therefore, the only thing we can do is infer pressure. And the best way to do it is using fluid mechanics modeling, or can we use ultrasound or MRI? Those are other two options. Oops. So basically, to get the vein and flow pressure relationship, you need to understand this equation here. It's called the Navier-Stokes equation. It too actually originated in Italy. It's quite complicated, but it actually allows us to understand the effects of gravity. So with ultrasound, when you're being put upright and supine, you can actually see exactly what's going on. It also actually accounts for the effects of interstitium. So basically, when you're laying down flat, the front weight of your neck is compressing the veins at the back of your neck. It accounts for that. And it can actually also include the periodicity from heart rate and respiration. So if we compare the techniques out there and we actually look at what's going on with the vein pressures, which we know are low, what actually happens is that the thin walls of the vein are easy collapse, particularly the ones at the back, with only 6 millimeters of mercury. That's next to nothing. So with an ultrasound, that transducer pressure alone can easily outdo 6 millimeters of mercury. With MRI, when you're lying flat, there's absolutely no effect. So what about the low pressure of respiration? Well, you know, you take a big breath in and out, you can actually increase or decrease your intrathoracic pressure by up to 12 millimeters of mercury. So therefore, with ultrasound, that needs to be regulated. But with MRI, using flow quantification, it's inherently averaged. So what about postural change, upright versus being supine? There's something called hydrostatic pressure. That's roughly changes by about 10 millimeters of mercury. So that's critical to the 5 diagnostic criteria used for ultrasound. Whereas for MRI, it's irrelevant, it doesn't matter. What about the heart rate? Well, it's quite periodic, we know that. And with ultrasound, you're actually going to see the effects of breathing, heart rate, and everything else like that. Whereas with MRI, it's actually inherently measured and normalized over heartbeat. So you're actually looking at a reproducible technique. So here, for example, is a picture of an ultrasound. Here you can actually see the effects of respiration in a vein. Also, the angle that the vein is being interrogated by is actually quite critical to Doppler ultrasound. And here, on the other hand, is what an MRI gives you. A standard MRI, we know that for MS it's commonly used. You actually look at all the lesions. We can actually look at the shape of the vein, and more importantly, we can actually look at the flow quantification. Basically, anything below this yellow line is moving down, going the proper direction, whereas anything at this line is basically not moving, irrespective of what this picture looks like. And a lot of the studies that have been done, all people have actually looked at is this picture, effectively useless. So now we can compare the MRI versus ultrasound. This was supposed to be my debate from earlier. So on an ultrasound, can we see the lesions in the brain and the spinal cord? Not a chance. Is it dependent on patient positioning and respiration? Well, ultrasound is, but MRI is not. So does the technique require specialized training? Ultrasound does, MRI doesn't. Can you visualize the multiple veins in the neck? Well, you easily can with MRI, and that's actually quite critical, whereas with ultrasound you only see the jugulars. So you can measure flow with both. You can actually look at the azygos only with MR, and basically their ultrasound is pretty plentiful, but the amount of people who can do it properly are not. Whereas MRI, well, they're pretty much everywhere. So basically, ultrasound can be used for evaluation of jugular vein flow as a new type of scanning procedure that's being applied to a new diagnosis, being CCSVI. So you're trying to take a new technique and apply it to something new. Good luck. If we actually go back and we look at what's happening in medicine, we know that medicine is very, very slow. In '92, there was a a physician who actually used a technique in ultrasound to try and look for genetic defects earlier than we normally do it at 18 weeks. He came up with this in 1992. It's actually taken close to 20 years for that to be accepted in medicine now, to actually try and look for something as simple as early chromosomal genetic abnormalities in utero. So good luck trying to get CCSVI and ultrasound working together in a few years, since it's only been around for about 4. So I kind of think the obvious winner in ultrasound versus MRI is fluid mechanics. Because we need to understand the science behind what we're looking for, and then you can actually use an appropriate test. So one of the benefits of fluid mechanics is that it accounts for all the effects of thin walls, veins, breathing, and it separates out the pathophysiologic process in health and disease in the veins. However, it's a little complicated. This is the equation you need to understand, and if you don't understand this equation, you really shouldn't be looking at vein flow at all. Because if you go and you simplify this, for the artery, you eliminate that entire equation, you drop out this one, you drop out this one, and you integrate it twice, and you get what we use in the artery. What we are taught in medical school, it does not apply to the veins whatsoever. So don't waste your time trying to look at the medical literature and read what they read unless this equation comes up. It is garbage. So this is a simplified version of it. And one of the big benefits with MR is that particularly with something called 4D phase contrast MR, we can actually mimic this right on. So MRI, I still say, is the best pre-op test for CCSVI because it is the de facto standard imaging modality for MS. It is reproducible and robust, widely available. It can be made operator independent, which is hopefully something we're going to work on this week. And it does also show us all the important veins of the head and neck. And so here you can see the advantage is clearly for MR. It shows what the neurologist wants to see. It shows what the interventional radiologist wants to see. And also, if done appropriately with the proper science, it can actually tell us what we're looking for appropriately. Thank you.
I'm glad we had him back up. I think we all learned something there. Okay, I'm going to turn this over now to Michael Dake. And to do the Doctors Roundtable, we'll call up, do you want to call him up or do you want me to call him up? Okay. So we have David Hubbard. Dr. Hubbard, do you want to come on up? Yolanda Arslan, William Code, David Williams, Charles Woodfield, Jack Burks, and Sal Sclafani. So, and I'm going to toss a question out here to you first. Okay, we had somebody from New Zealand that asked if there is any way to have a standardization of costs for the procedure and for imaging throughout the United States. My answer was, I don't think so, but okay, here you go.
Thanks, Sharon. And before we get to that question, I think this is probably one of the most fun times for you in the audience because you can ask whatever you want to this panel of experts, and you got a slight flavor of what can happen when we let these guys talk spontaneously. We need one more chair. There's a chair. Here's a chair. You can stay standing. Okay. But and we can. I think all is fair. We have lots of different focuses up here. And so let's just toss that out there. And I think your initial impression is right, Sharon, that there is no way right now that we can consider how to standardize a cost for either imaging or treatment in our country because it's not recognized as anything that anyone would pay for yet. So that creates an issue. I don't know if any thought on that. I think it's just a little early. Let me throw a corollary to Jack. You know, Jack, you and I have been sort of sharing I don't know, on certain programs for about 2 years. And my sense is we're sort of, even though it's only 2 years, I feel a little like we're in a period of sort of like we're a little aground right now in this because I personally feel that I agree with you that we need to get data to convince your average neurologist, but getting the vanguard of first neurologists to break the tyranny of their peers, which basically sees anyone as, you know, potentially being, a heretic if they step out of line here. And I think this is a real issue. And it's not something to say we need to see the data, because the only way we get data that people are going to believe is if we have collaboration with neurology. So what fundamentally going forward, how do we get at this? Because I tell you, I've been to IRBs at 5 hospitals now, and I get interested neurologists, and whenever it gets up to the IRB after working for 2 months, I just can't do it. I just can't do it. Why can't you do it? What do we need? I just can't do it. And what they're saying is, in so many words, is I don't want to be professionally outcast in my specialty.
I feel that way because I feel like I am being professionally outcast just by coming to a meeting and saying we need to work together to get the answers. Because neurologists, I think, may perceive that as I'm out here promoting, and people have actually told me that. Nobody here at this meeting says I'm promoting this. What I'm promoting is, and the way I think we should frame it, is can we get together and promote research? And that's what, I mean, if somebody comes to me and says, I want CCSVI, my job is to find out the place that has the best research component, has an IRB, has follow-up, is going to work with me as a doctor, giving me reports. Most doctors don't get reports. If we framed it in the terms of we have a theory with some preliminary data that has holes, but it's some preliminary data that we need to go to the next step. And because all neurologists want data, they want research. So if we could frame it as we want to see if this thing, we want to prove this thing works. Boy, neurologists get turned off. Our job is to look at it objectively. Our job is not to prove something works. It's to get the right answers. And so my feeling is that the patients need to understand and the doctors need to understand that you need an IRB, you need follow-up, you need criteria for restenosis. I'm not saying don't have it. If people want to do it, I refer them. I usually call Sharon and ask her who the best person in their area is because she knows who's the best people. But I think it should be reframed.
Well, I think I agree with you, and I don't think anyone would disagree. I think our real problem is what I'm trying to get to is we can't go to an IRB without a neurologist. Neurologists are the eminent, they have domain expertise. If I go to an IRB and want to do something like you're suggesting and say, I don't know if this is right or wrong, but with 30,000 people being treated, why shouldn't we be the ones to do a study and be authorities to answer these questions? And they say, where's your neurologist? And I can't get any neurologist because, as you say, there's this sort of tendency to lump this for certain convenience sake with bee stings and snake venom.
Well,
I think this is, I think one of the things is where we're left, and I'm often in certain situations the opposite of what you are here. I'm the one who's taking, the paintball slings coming, and it's sort of, the question always is, well, what about the organ of something, and it can't possibly, and I get myself arguing about these associations, which we're never going to prove in the short term. And I think we're a little phase shifted out of whack. What I think we ought to be is, if we treat patients with this finding and observation, we don't really know what the association is. But they get better, and you talked about quality of life and all of these other issues, and we can demonstrate with randomized, sham-controlled studies that there is some measurable, quantifiable, objective change pre and post that correlates with symptom improvement. That's what we ought to look at, instead of trying to figure out every little pathophysiologic, organ in the body,
You're so right. I agree with you 100%. And one of my missions in life is to get the groups together, to sit down in a room in a conference and saying, what do you know, what do we don't know, how can we work together? And then we have a paper at the end saying this is the strategy that we all agree upon. If this strategy shows something, then we'll all agree to it. Because right now, the interventionists have their own strategy. Neurologists aren't really involved with it, so therefore we're not going to believe it. But if we actually sat in a room and I said, Mike, yeah, I agree with that. If you can show me that that works, I'll put my name on that paper. But even just having the paper, a document that says, this is the strategy, this is the research strategy. Now, if you want me to go to a hospital and say, do it commercially, no, I'm never going to promote this commercially. I'm promoting this in clinical trials and research. Every doctor today has said, do research. We're all saying the same thing, and I'm saying just don't do it commercially. Because you don't know what you're getting, you don't have follow-up, et cetera. But I think if we had a white paper or some sort of a consensus paper of all these different specialists saying, we've met together, we've reviewed the data, here's the data, this is the positive, this is the negative, and we need to have more data to where to go forward. And you take that to an IRB and you have the names of prominent neurologists on that as well, it's going to mean something. And right now we don't have that because we think that these guys are just running loose, trying to cure MS when they don't know what they're talking about. So that's what we need.
Okay, we're going to open it up. But while we're getting a question that we've had some questions submitted, so I want to give them a little airtime before we go to the audience. What should we be doing about general practitioners? How do we educate them? Should we be in some way talking to them in a way like because obviously it's not working that well with neurologists. Is there anything, because most general practitioners are standing back thinking this is sort of some pseudoscience, not really, any thoughts? That's not my question, it's a question from the audience. So is there something that should be done to have similar meetings with general practitioners, or what do you think, Sal?
Well, in the survey that I'm still working on, 90% of the practitioners have never gotten a referral from either a neurologist or a family practitioner, a generalist. And my gut sense is telling me that the family practitioners are not going to follow the lead of an interventional radiologist on something as complicated as multiple sclerosis. So I don't think that will work because there's no wait. I think they're going to wait for the neurologist to drop the other foot. Unfortunately, they've already dropped one foot and it's gone on our heads, but.
Okay, Bill, what do you think? You had to comment.
Well, this comes up all the time, of course, in Canada, because, as was mentioned earlier, a lot of patients come from Canada. Almost all of them still have the support of their family doc. And if they don't, they find another family doc, because sometimes they're needing a prescription. And fortunately, typically the prescriptions at home in Canada for the same agents we talked about earlier are a little less expensive, and sometimes they're even covered. Not always, but sometimes. But many of the general practitioners have filled in the slot and say, I will support you. Now, we know that each general practitioner in Canada, typically we only have 3 MS patients in their practice in their lifetime. It's not very many. But most of them have developed a long-term rapport with them, day in and day out, year after year. So I honestly believe in the short term, we have to educate those people with the best we can with regard to the follow-up and the note or whatever pieces that we can so that they feel involved. Because if they can feel involved, then they will do as much follow-up as we can. And it becomes really obvious right away when we talk about preventing thrombosis, because there's nothing to treat thrombosis in Canada if you have one. So you better stay out of the hole. And that's why I'm a huge advocate of Dr. Robitaille, the hematologist at the Heart Institute of Montreal's concept of Pradaxa, because you're a lot less likely to have a thrombosis on that than nothing.
Okay, I want to remind the audience, in addition to the sort of down the center of the fairway CCSVI talks and discussants, we also had David Williams and Charles Woodford, who gave us some very interesting talks. So we want to please think about those talks and any questions you might have. These are the guys who can answer it. So let's open it up. Yes? No, right behind you. I don't think that's on, yeah. If we can get it working, then we don't have to repeat. There we go.
Okay. My surgeon said, yeah, he could go through the procedure of doing a sham, but he'd really have to give everybody a general anesthetic to do a double-blind controlled study, which means he doesn't have input from the patient and he doesn't have the patient cooperation. I can tell you that when somebody blows up that balloon in your vein, you will know it. You'll probably also know it for about 2 or 3 weeks afterwards. So there, with something like this, there are much greater difficulties with doing a double-blind study. And I would like to challenge the idea that a double-blind study is the only kind of evidence that's any good. There's another method that doesn't involve big groups of patients. It doesn't involve comparing, just statistical comparisons, but works with individual patients. It's called the challenge, de-challenge, re-challenge. If somebody's got a symptom and you want to know if it's an allergy, what do? You stop the suspect. The rash goes away, that's, it's suspicious. You want to prove that it was a peanut allergy? Give him some more peanuts if you dare. And if he gets the symptoms again, then that's very good evidence that it was a cause. Now, if somebody has CCSVI and has symptoms of multiple sclerosis, you relieve the CCSVI and they get better. If the stenosis recurs and they get worse, I call that evidence.
Well, I think we've all had experiences with patients, because there is a high recidivism rate after angioplasty. But let's ask Bulent, what's your experience with the challenge, re-challenge in terms of when patients come back to you? What are you finding?
Yeah, I have something to say about that. Dr. Burks is obviously the most open-minded neurologist. I had the luck of working with a couple others, so I've been in a better environment compared to most interventional radiologists. But about the trials, everyone agrees that you need trials. But comparing like snake oil, etc., to CCSVI is not fair. Let's look at the other side of the coin. No. Why not compare this to carotid disease? I don't know if most of you know it. Carotid disease has been around for many years. Surgeons have been treating it in the 1950s, and neurologists didn't believe the benefit of it. They never referred the patients to surgeons, even if the patient had a stroke or mini stroke, until 1982, where a large scale, 30 years later, trial was conducted, and the trial showed that compared to best medical treatment, if you had a surgical cleaning up of your blocked carotid artery, you were much less likely to have another stroke and maybe die. So only after then, the neurologists started to send patients to surgeons on a routine basis. So what happened to those patients in the 30 years who could have benefited? That's the other side of the coin. So this may be wrong. We need to prove it on a clinical trial. But we're not comparing to snake oil because snake oil has no proven relation. We're treating patients only if they have a significant blockage by venogram. Even if ultrasound shows something suspicious, I don't see a blockage on the venogram, I don't treat that patient. So, and you're not supposed to have blockages. Nobody's supposed to have blockages naturally occurring in their veins. So to relate that is more likely like the carotid stenosis or somebody's bleeding from their artery from a trauma. Am I going to have a trial to see if I should just press on it? So we have to kind of... I'm just putting I'm not saying that this should be the way we should go. We need the trials, but that's the other side of the coin. So that's all I'm going to say. I think we're just looking at it from one perspective only. Obviously, we need to prove ourselves, but you also need to not leave the patients alone saying that we just need a trial.
So, Sal, will you address specifically this challenge, re-challenge, in terms of when patients return to you and they said, I had a benefit, but now, doc, it's 6 months later and stuff's starting to come back. Not everything's coming back, but I'm not, what do you think about that? And what do you find when you restudy it?
That's very, very difficult. There are some patients who I'm better now than I was when I first started, so that I find things that weren't found before. There are patients who have secondary progressive or late primary progressive disease, and I think some of that probably could be placebo, and the second time around I don't get a response. But it's all subjective still. So it has benefit. I think it's not it may be better than the best option that's rational, because we can't blind patients. It's impossible. I don't see how we can blind patients. But I don't think we have enough answers yet. I think we have to have more objective data about how to measure the flow effects. forget about whether we improve the symptoms of MS. If a balloon angioplasty may have positive benefit in a 20-year cycle that relates to that absence of that physiological derangement, that may not improve symptoms at all. So I don't think you can just use that. But flow, if you have an obstruction to flow and you improve the flow, we're not going to get all the answers right away. We're just not. But we have to measure whether we're improving flow or not. That's all.
Okay. Yes.
Well, I think regarding to that question, I think that it's going to be really important for the patients long term. And long term, I'm talking about years, not probably months, because I have a couple of patients that I had to stent a jugular vein because they had thrombosis immediately after the angioplasty, and the patient was doing great. And one day, 3 months after she had the stent placed, she called me and she said, my stent is thrombosed. And I go like, how do you know? Because I have the symptoms again. I said, tomorrow you're here. Took a look at it. Sure enough, the stent was occluded. Open it up. She felt better. And I have a couple of situations like that. But what's going to happen? We need to see a lot of patients so that we can prove that.
Yeah.
And it's going to have to be long-term
I think
follow-up.
that was the point. There is, I think, a general, what do I want to say? A general sense that when patients come back with symptoms and they know something is different, that when they're studied in some frequency, they're re-narrowed, and we just don't have a good handle on accurately telling how often that occurs. But I think people have been impressed with that. Yes, Jerry.
Actually, I'll pose a question to the panel. Let's say that we fast forward 5 years from now and we have a randomized trial with placebo. What value above placebo effect do you consider compelling that it would be reasonable that this procedure is, efficacious and should be offered to patients? So what should be the threshold that this procedure has to meet in your minds? Because we're all saying we have to do the research, but
you're looking at me, so I'll respond. I've tried to avoid being specific. I just said people should get in the room together and let them decide. Let's have a discussion among the experts as to what should be decided. I mean, I have my own ideas, and I think the lady who talked about the test-retest test, that's the sort of things that we could bring up in this conference. What are the pros and cons of that? Like, my own bias is that we could do an effective comparative analysis, potentially. In other words, you have 3 groups. One gets CCSVI in a known treatment, one gets CCSVI alone, and the third gets the known treatment alone, an FDA-approved treatment. And then you actually have 3 groups of patients that you could actually follow. It's along the idea of, can we get away from giving patients anesthesia and getting rid of the placebo effect? I think if you have a comparative effective analysis, which the FDA is actually promoting and might actually fund something like this through the federal government, there may be ways that we don't need placebo groups or sham operations the way we typically think of it. So I think you're right. You're thinking about the right ideas about how we could redesign this. But I think we need to get the experts together to say, is 10% enough? Do you need 50% difference? And I don't think we can answer that question today.
What are the specific endpoints? I mean, 10%, 50% of what?
Depends on what you're measuring.
I know, but what is going to be the most compelling measurement? Do we have to go to MR lesions? It's something that goes that long is going to be difficult to sell patients on in a randomized way.
Well, you have to define your outcomes. If the claim is that CCSVI is a disease-modifying therapy, then we have criteria for disease-modifying therapies. If CCSVI is a treatment for fatigue, bladder, pain, et cetera, then we get the measurements for those as well. It depends on what we want to measure. So we can't say, maybe for relapse rates it's 30%, but maybe for fatigue it should be 80%. I don't know. But there are experts who know the answers to those questions of what's a meaningful change that we could report.
Well, I guess some of these subjective things get me a little more nervous because I'm always afraid that neurologists are going to just poo-poo that and say, no matter what, it's just a subjective placebo, even if it's 100%.
Yeah, we're changing. We now have symptomatic treatment, so we actually developing scales for these. Like we have fatigue scales. We have walking scales. We have all these other scales now that we're now believers of, and we have FDA-approved drugs for these various things based on these scales that are not disease-modifying scales, but they're symptom management, quality of life scales. And I think you could get neurologists to buy into those.
Okay, fair enough. Barbara. Oh, wait for the microphone, okay?
Thank you, doctors. I've had MS for 24 years. I was in the Rebif study, so I took Rebif for 11 years during the relapsing remitting stage. That should have stopped me from getting secondary progressive, but I still got secondary progressive. Once I got secondary progressive, they gave me Novantron for 2 years. Didn't do anything. I still got worse. When the CCSVI came out, I couldn't find a doctor. No neurologist would agree to this. So I took it upon myself to find an interventional radiologist, and I found Dr. Arslan. I was his first patient, and he did the procedure for me. 4 hours after the procedure, I was in a wheelchair, and 4 hours afterwards, I walked. And for one entire year, I had 2 procedures, and I walked for an entire year. I went and had the procedure again for the 3rd time, and I'd been having a lot of stress, and I was in a wheelchair again. I had it 2 months later, and I have had thrush. I don't know if the stress that I've had, this thrush, that I've had it for 2 months, and I can't get rid of it. And they don't know what type of fungus I have, and I haven't gotten the correct medication to get rid of it, has caused me not to be able to get out of the wheelchair completely again. And he did place a stent. I'm not as well as I was. I don't believe that this is placebo. I believe that secondary progressive people can get better. I don't know what your threshold is to understand. MS is different on everybody. Everyone's going to have a different reaction to this procedure. No 2 people are the same. I advocate for this procedure because I have been on very different medications and nothing ever worked like this procedure worked. Okay, it's not working on me currently. I do have energy, and I believe in this. And I think that the earlier you get this procedure done, the better I think you will do with MS. Newly diagnosed patients, I believe, do much better. I'm an advocate for this, and I just, I hear, more testing, but, we are in jail in our bodies. This is a prison that we live in, and it's like, please, people just be advocates, find your interventional radiologist and get it done, and don't get to our stage where it's very difficult to a point that we can't get back our years. That's all I have to say. Thank you.
Thank you. Cynthia?
By going to Arslan, because they're measuring their results. They're doing the right things. So you pick the right place, and that's all I'm suggesting is pick the right place.
Questions? Cynthia, do you want to ask a question?
Hi. I have MS, and Dr. Dake actually treated me in 2009 and also again last year. And it's really helped me a lot. I don't know where I would be today had I not had these treatments. And my question to Dr. Burks is you're saying that you all need to get together in a room and discuss and agree, but if Dr. Dake can't get a neurologist to get in a room with him to discuss this so they can take it further, how is it ever supposed to go any further? And I had to be my own health advocate and search this out when the information first came out, and call Dr. Dake's office and, say, will you see me? And, I just don't know, like Barbara said, what are other patients going to do if they, if we can't bring this further and get some help and get the doctors together where we can, move this on.
So this theme has come up a lot, and let me put a little different twist on it. So we've got Bob Fox, who's out there, at least he's writing articles, he's engaged in something. He's I think, agnostic is correct characterization. How does that play? Does that have any effect on the neurology, or is this just? I get this feeling. I really believe what you said, Jack. That a lot of neurologists want this to go away. You know, and I don't. If we just kind of stonewall, create a, that this can't go forward without us, being a participant. And if we don't participate and just say, show us the data before we're going to, it's kind of.
Really need the neurologist, need the insurance companies, and that's why there's got to be
Well, I think that there's been a lot of progress. We have 2 or 3 trials that are FDA approved. I mean, that speaks to neurologists. Neurologists, okay, great, they're trying to do this seriously.
But these are not treatment trials, right?
No, these are Dr. Siskin's trial is FDA approved, as I'm.
FDA doesn't approve trials.
FDA is not
Did he get a
involved.
review from the FDA to say?
That's an IRB.
Somebody said in this one of the talks that they were FDA. They were FDA approved, and we did one in the snake venom with the organization I work at because we heard similar stories at snake venom. We actually got one of the major universities in Washington D.C. and the FDA actually approved this trial. We went to them and said, "Is this the outcomes that you would believe?" And they said yes. And it helped us with the neurologist. It turns out it didn't work. But at least we tried. We had made some effort. And I think that...
Well, wait, Jack, get back to my question here. Is what do they think of Bob Fox? Is he sort of just kind of... Are they people listening?
Bob Fox is a leader in neurology.
So what's been in the neurology world? What's been the response to his sort of saying, "Look, we should we don't know, but this I think at this point is something that needs our attention."
I think that if Bob Fox, who's a major leader in MS and runs one of the best MS centers, and I think he's the clinical director of the Cleveland Clinic, and you get 5 or 6 other people like that, and there are those people that are saying, "Okay, I'll sit down and look at the data. I don't have to believe it, but I'll sit down and at least help design trials for that." I think you're there now, and the key is to get together. But the neurologists have to be convinced that the other doctors involved in this really are serious about getting data. If they were here today and heard everybody say, "Let's get data," everybody would say that. But they're not here. So it's a process. Why they're not here? I'll tell you why they're not here. If you really want me to be honest, is that this came to their attention by the newspapers who said there is a liberation of multiple sclerosis procedure being done that's going to be curing multiple sclerosis patients. And I'll tell you that we made a mistake. We should have said, there's some preliminary data that we want your help trying to develop more trials. So therefore, they're reacting as that everybody thinks this is liberation. This is going to cure MS. Well, nobody in this room thinks this is going to cure MS. But the neurologists, that's what they hear, and frankly, that's what the blogs on the internet say.
I don't disagree with you, Jack.
Why are they not here at this meeting? That's what I want to know, because they don't want to hear it, Jack.
Well, I think that you're right for a large part because they think that there's not enough data to pay any attention to it. We have more important things to do. But there are people like Bob Fox and the Cleveland Clinic and other people who said, "Yeah, let's give it a look." But right now, they would say, "You haven't proven a thing. Until you give me some data that proves anything, why should I waste my time doing this? I've got other research I want to do."
Okay, a lot of hands are up. Now, what I'm going to ask the hands that are up, I want short, concise questions, not comments or opinions. So if you don't have a question, you won't get called on. Question.
You haven't mentioned drugs, and I want to know. I was put on Copaxone immediately I was diagnosed. I took that drug for 5 years. I have no idea whether it did any good at all. I suddenly saw the sense of coming off a very expensive drug, and it's made no difference at all to me, and I've not gone back on any drugs. No one's brought up treatments of drugs today.
Okay, and what about treatment of drugs?
Well, does anyone believe in a treatment of drugs?
No. Well, I can sit here and give you data. But let me give you a personal experience. I ran the largest MS center in the world for 20 years at the University of Colorado, called the Rocky Mountain MS Center. We had 5,000 patients. My waiting room was about half the size of this room. It was full of wheelchairs in 1990. I used to go in and make wheelchair runs. I mean, just to get to meet the patients and say hi. Very few people who get treated within the first few years, get treated under the age of 30, are now in wheelchairs. And this has been out now 20 years almost. So therefore, it's been a huge difference in the population. There are certain patients that don't respond to anything. They just don't respond to anything. People with progressive disease that don't have relapses, I don't think respond to anything. The data's there. You know, they've been tried. It doesn't seem to work. But young people with relapsing remitting disease, I think it would be a shame to say these drugs don't help, because they really do help.
And I think I agree with you, Jack, but remember within the last year we've had the quality life year. They do work, but at a cost that is just way out of bounds, and that's because of the cost of the medication. $850,000 for quality adjusted life year, which is 9 to 10 times more than what anyone would consider effective. So
we're not talking about cost. We're talking about treatment. Do they work? The answer is yes. Are they cost effective? That's up to other people besides me.
Okay. Next question, Marsha. Yep.
Hi, everybody. My name is Marsha Mays. I'd like doctors to answer this. How many years do we give a placebo effect? That's number one. Number two is I couldn't sit up in a wheelchair. I couldn't even hold a fork. Okay, and I have 3 children. So how long am I supposed to wait? Am I supposed to wait 15 years until it's FDA approved? Or do I wait till I'm dead? When am I allowed? When does the placebo end? That's what I'd like to know, because it's been 2 years, and now I can walk, now I can see, now I can drive, now I can remember things. So I'd like to know, how long is the placebo? I'd just like to know an answer to that.
That's a great question, and I think that's a fair question, because I will tell you that in our group looking at fatigue score, 2 months could easily be placebo. We all know that. A year, and I still have fatigue scores going down and relapsing remitting. Not a lot, but certainly not going up. So and that's in a series of 50. So when is it a point where we can actually say the born-on date of placebo is expired? There's probably
there
not.
There is no date.
There is no date. So what would you think is reasonable?
Okay, Dave, go ahead.
So I reviewed this whole sort of placebo thing just because, it's coming up. So there's a whole literature in general, placebos, not just related to MS. 3 months. 3 months is enough time to decide whether it's a placebo.
So are you saying that I'm over my placebo time now? I'm free? Am I free now? Am I free to walk? Because look, I can stand on 1 foot now, see? Couldn't do that 2 years ago. I couldn't see, for heaven's sakes. My other question is, my comment is, I've done all your drugs except for Tisabri. Why is it that Tisabri is just rushed through FDA approval and not angioplasty, who's been used for so many other different ailments? Why do I have to wait, but you're rushing everything else, and people are dying? I didn't die from my angioplasty. Did anybody here die from their angioplasty? Raise your hand. Oh, okay. So I don't understand, how is it that we have to keep waiting? What do we have to prove? I don't have 15 years. My youngest daughter is 10 years old. And if I didn't have my... I'm sorry, honey. You're all good. I'm sorry about that.
Okay.
What I wanted to say is that my daughter is 10 years old. If I didn't have my angioplasty and I couldn't walk, I couldn't see, I couldn't sit in my chair, and I couldn't feed myself, where would I be now? I'm in a wheelchair. Where would I be? What are my options? Can any of the neurologists tell me where I would be? Since you're a neurologist and you know so much about my brain, could you please tell me where I would be? Because you know what? I saw my neurologist the other day, and I asked him for an MRI. He says, "Oh, there's no need." For what? He let me go. He says, "Just call me on an as-needed basis." So that means I don't have to pay him $200 every other month for him to tap me on my knee and for me to touch my nose. So what do I need a neurologist for at this point? My interventional radiologist saved my life, and now I can be a mother.
Well, that's very powerful, Marsha. Thanks. Go ahead, and then you'll go next, okay?
I just have a real quick question, and it's very simple, and I don't mean to be facetious, but is it normal for a double-blind study to be required for a structural defect? Is that normal? Like a broken arm or... It's a pharmaceutical model. Is there another example of that anywhere?
I think that I can take that unless somebody else wants to take that. It's usually normal if something's going for an approval that you have to basically try it as a treatment versus whatever the control currently established treatment is. In terms of this, it's obviously a gray area, but I would say that everyone is trying to do something that we think can compel neurologists to be involved. A study that they would really feel could offer some prima facie evidence that something's going on. So that's why we keep talking about randomized blinded studies, because we think that's the only way that neurologists would even at least consider getting involved. If it's going to be a registry or something like that, we've sort of heard time and again, doesn't mean anything. So that's why I think in this particular case, everyone would like to get to that highest bar in terms of proof that we could try and get neurologists to collaborate on it. Yes, why don't you next? Yeah.
Please forgive me for if I get the facts wrong. I'm going to repeat some stuff that I saw on the internet. But I believe that Dr. Zamboni convinced Dr. Salvi, who is his neurologist, to partnership with him. And he had some difficulty at first getting him to buy into it. And I believe that he referenced it today, that he had 18 patients that were in the throes of an acute exacerbation when he did angioplasty. And I think that that would be the best way to do it the fastest. The sham studies is to have partnerships where one neurologist and one IR work together, and they alternate patients presenting an acute exacerbation every other one. One gets steroids and one gets.
I hear you, Jack. What do you think of that?
I think that if we did a study of Tisabri versus CCSVI, half the people blinded or randomized get Tisabri and half the people get CCSVI, and it's as good as Tisabri, that it will be a major treatment for MS.
Not the DMDs. I'm talking steroids. I'm talking acute exacerbation. I'm not talking DMDs. I'm talking somebody presents with a Bell's palsy or a paralysis or an acute exacerbation where immediately the next day they would get a angioplasty, and then the other, every other patient would get steroids in the IV and in ER.
I believe that was a treatment for exacerbations, because I can tell you steroids, some patients don't work at all, but most of the patients it works dramatically. People get up and walk within 2 days of getting steroids sometimes. But I've seen people get up and walk in 2 days with nothing. They'll call me on a Friday and they'll be bedridden, and I'll say, I need to get some tests. We'll start it on Monday, and by Monday they're better.
So I guess the answer
so we have to have a control group.
No.
That's the point.
His answer is no.
We need a control group.
Yes. Question in the back. Questions now. Just questions.
Could I just share some information with you? I'm from Scotland, and we've introduced this procedure over the last year. The results are coming through, and again, they're a bit spurious, and people are relapsing. And what we've undertaken in Scotland is that pre-op, pre-procedure, we're screening people for craniomandibular and spinal and cranial issues. We are doing that, and the results are coming through. And I'd like to share that with you, because, it's just a sea of words and data, and that's not good enough for people. This says people, you're not treating pictures, you're treating real people, gentlemen. And the sad fact is that if a patient presents with a problem, they go to their GP, the GP says, look, I know the guy for you, I'm going to send you to a medical electrician. He's called a neurologist. They go to the medical electrician, and he says, well, look, I've done the electrics, and there's not a lot I can offer you. I'm going to send you to the medical chemist. The medical chemist will give you preparations and drugs and things that will help you. And you're a patient, and you're all this conflicting evidence. And then someone comes along and says, well, it's not electrics, it's not chemistry, it's plumbing. It's plumbing and central heating. The patient is totally confused with this. Patients aren't being given choice. They're being given words, data, that's of no value to them. And along comes a guy like me and David and our friend with the Atlas Axis, structural guys looking at structural problems. So the structural engineer comes along and says, well, don't listen to the electrician, don't listen to the chemist, don't listen to the plumber. And by the way, we do information processing, the autonomic nervous system. Take on board what David said and the structural guys have said. We've implemented that in the UK, and we're getting results in the patients who have relapsed. We've cleared them, and we're giving them counselling pre-op to have this matter dealt with before undergoing any procedure at all. Patient choice.
Okay. Now, I'm going to make myself clear. Questions. No one seems to be wanting to hear what I'm saying, but questions. Okay, who has a question? Question.
This is the placebo effect of a microphone. I'm guessing that there is a surfeit of data available now, but it is just not coalesced and analyzed. And I'm guessing, David, you've talked a couple of times, or you hinted about the repository. What would that do to people, or, you know, having maybe patients advocating to their docs to go to the repository and then have a meta-analysis on that? I'm just spitballing here, but I'd like to hear about your repository.
So there have been about 600 patients treated in one of the two registries. It's been accepted at the JVIR journal. It's going to come out soon, at least the first 260 of them. It shows that 55% are getting better at 6 months. But insurance companies are never going to pay for it until there's a double-blind placebo control. Everyone can have the procedure if they've got $15,000. To me, the next step is, yes, get the neurologist involved if they will, but primary care docs will make the referral. So from that point of view, we really, unfortunately, if we want insurance to pay for it, which right now only 2 or 3 carriers are covering, we have to get 2, probably 3 double-blind placebo-controlled trials. It's sad, but it's not that terrible. I mean, you know, it's just a balloon. You know, it can be done. And then the other piece has to be the science. We have to be able to have some reason to believe it makes sense. It's not a jugular problem. It's a central nervous system problem. I'm putting my money on that it's a hypoperfusion problem. But until we have some reason to think the neck's connected to the brain, we're going to have that sort of more, I call it neuroscience problem. But the double blind is going to have to be done if we want insurance to pay for it.
Now, the other thing we didn't talk about, which is not the number one reason we're not getting these trials done, but it's something that follows once we get collaboration, is who's going to pay for these trials. You can't have a sham-controlled trial and have, you know, one arm pay and the other arm not pay. You can't. It's got to be completely, so that getting that money together. But I'm telling you, that is not the real issue. The real issue is getting neurology to be willing to get involved. Okay, question. Question. Oh, you're next.
Or obstruction of the veins as one of the possibilities. And since I know that in Italy and in Greece, where I work, they do not use stents and zambonis in MS patients because they often got tree stenosis. What I'm heading at is, did anybody of you compare the rate of tree stenosis in patients with MS, which has been treated with ICSUI, which were stented or not? Or the reason is the Lancet paper many years ago showing that patients who get restenosis have very often positive to the material in the stents. And in our own material, over 140 MS patients, 80% are clinically nickel allergic. And you use in the stents stainless steel containing nickel cobalt crown, and you use this drug to elute, to prohibit stenosis. So did you anywhere compare? You already must have the data.
The answer to that is no. What I learned from you is that 80% of people with MS are allergic to nickel. What else are they allergic to? Metals. Everything. Okay, well, there you go. Okay, question.
Mike, the majority of patients and the majority of the physicians treating those patients do not have stents. Most people do not use stents in the United States. The indication for stents are very, very finite and very clear. They usually, most of the time, are desperation maneuvers. It's not a routine at all anymore.
Yes. Could we get the microphone right here?
I almost forgot what I was going to ask. Since Dr. Burke, you talk so much about getting people together and having experts, do you consider yourself an expert that could be amongst these people who are experts in their fields to lend credence? And also, I have an idea on how to maybe convince the neurologist that there is some improvement. I had improvement after my treatment. I've since regressed a bit and have that vein occlusion issue. But I think that maybe if we had some computer programs to assess the cognitive functions, most of us that are treated say the first thing that lifts is the cognitive fogginess that we have. Could there be a computer that would assess those areas so that that would do away with the placebo
effect? To answer your question,
effect?
there are plenty of validated inventories of cognitive function that use computers or not. And that's available, but still you need to have, in my way of thinking, you'd like to do this in a way that people could agree beforehand that these are things that we will, if no matter how they turn out, we can agree that they were fair.
The only assessment sheets that I've ever filled out were the ones that say, you know, can you go up so many flights of stairs today? And, you know, did you do that before the treatment?
Oh, they're batteries.
Those are so subjective.
They're batteries that can look at cognitive function very easily on a computer. Yeah.
So you would have to just get your team of doctors together on this beforehand. So we're sort of back to square one.
But good points. Yes. Well, whoever gets the microphone first, yeah. On the side and then back to the back.
Hello. I think we have to start with our mouth first, the dental. We have half of our problems because our teeth are bad, because we have things in our mouth for 30, 35 years already. That's messing up everything. We know that it starts in the mouth. And also chiropractor. I mean, we have these two guys up there, and nobody's talking to them, and I think they're first before we get this CCSVI. We need to get this fixed first, because that's always going to be our problem, and we're going to always have problems.
I think you raise a good point, and I encourage before we start to ask some questions to David and to Charles. But I think that it takes a critical mass of people to actually, I think, put out there what the frequency of some of these things are in MS patients, so that you get some momentum built on. I'm very open to listening to all these things. I agree with you, but it has to get more than a small group. It needs to kind of organically build so that people understand, you know, and kind of build on each step. And obviously, David showed, a lot of material that he's worked on that has a thread to it, and you can follow the string, but it's still, obviously, all these things have a long way to go. Yes, back, and then we'll go to...
Hi, I'm Landon Schmidt with the National CCSVI Society, and my question is about compassionate care. And I think I'm going to address this to the entire panel, but in particular Dr. Burks. Do you agree with compassionate care called for and supported by Dr. Zamboni in the absence of any other treatment?
The answer to that is I feel very compassionate about my patients. Whatever I can do to compassionately help them, I'm actually for that. You have to define specifically what you would want for them, though I'm not sure exactly what you talk about compassionate care. Help me with that just a little bit.
Basically, I'm looking to find out whether or not compassionate care in terms of CCSVI treatment would be something that you would promote in advance of the trials and your data.
People come to me and say they want CCSVI. I say, where do you live? I'll find someone around to do it. I said, I wouldn't recommend it, but if you want it, I'll help you find somebody who will do it the right way. Is that compassionate care? Or are you talking about financing? No, you're not talking about. You're talking about.
No, not talking about
I
financing.
think that's what I'd like to have neurologists. If they could just understand who's doing the work, that could be helpful to patients. So they're not getting it in the strip mall by some commercial artist who really doesn't know how to make a diagnosis of the disease and has very little experience in operating on it. That's what concerns me. It's not the people who are sitting on this panel who do it, who are experts in doing it, because they're going to be collecting data that's going to help me understand the disease. So I think many neurologists would be open to that if they understood the amount of research that's going on. And this meeting is going to help that. And if we have this conference, What Do We Know conference, that's going to help it because the neurologists are going to be involved in that. And it's going to be their colleagues who are writing it as well as the people on this panel. I think we're heading in the right direction. I think it's time. I wish we'd have done it in 2009 when Dr. Zamboni's first came out. But there was a mistake, a block. Let's correct it. Let's take a step back and do it right this time.
Okay, last question, Carol. And because some of us have got to go over to another meeting here, a scientific meeting that's starting. So we're going to finish up at 4 o'clock, and it's a little after 4. So, Carol, last question.
Okay, this question relates back to the snake venom and bee venom. I'm curious to know if they ever did any studies with regards to the bee venom. I had never heard that as a treatment for MS until I came to my neurologist and talked to her about CCSVI, and she said, oh my God, that's just like bee venom. And I thought, oh, a light bulb went off in my head because I got my degree in entomology, and I know that bee venom is a major vasodilator. So I want to know, did anyone look at it, and did anyone find it effective?
The MSAA, the Multiple Sclerosis Association of America, which I'm the chief medical officer, funded a study, and it was done in collaboration with the FDA because we wanted to make sure it was legitimate. And it was either Georgetown or George Washington, and it was one of the big universities, medical schools in Washington, D.C. They did the study. They did not find any benefit, and it essentially died in this country after that. If it had been positive, you know, these things would be here. We wouldn't need CCSVI because everybody would be better. But people who got bee stings stood up more vehemently than the people in this room have stood up and said, "How dare you keep me from bee stings?" I'm not keeping you from bee stings. I'm saying we don't have the data. It became such an issue that the MSAA actually funded the study. And when it was done legitimately, and they said it just doesn't work. There was even some suggestions that it made people worse.
Okay.
I don't know.
Oh, I'm sorry. Okay, I was just going to say we're just about at 4 o'clock, and I think that people ought to maybe go back if you're to your rooms or whatever, and then there will be the reception. But I do have one other question here for all of you doctors. And that is, as a patient with MS who has been treated for CCSVI, has had improvements, and has also had some things that have gone back a bit, I just want to know, are you all, with all of this discussion that's gone on this morning, are you going to stick with us? With the MS patient community, are you going to stick with us on this until we get it figured out? Okay.
That's a loaded question.
Okay, Linda Safran, where do you? Is the reception over in the room where we had lunch? Do you know? Okay, so and that is starts at 5 o'clock. So please, relax for a while, and we'll see you at 5 o'clock. You can all speak with Dr. Zvadnov. Yes.
One last remark. So Dr. Burks here is the most open-minded neurologist because he's the only one who is here. He's
yes.
Being kind of,
yeah.
So I know
yes.
We are, we have, different perspectives, but he is open. I'm sorry, Dr.
And Dr. Yes.
He is all open to it. So, but it's important that to work with them because there's a lot of MS patients with neurology care. This is a neurological disease. So we have to come to the same grounds eventually. That's it.
Yeah. Okay, thank you all of the doctors here, the doctors that are still in the audience, to the ISNVD. I hope that you all have enjoyed this. I hope that you've learned something from it. And please go out and take that knowledge to others, okay? Thank you very much for all your support.